Bismillahirrahmanirrahim. Assalamu alaikum. I welcome everyone to today's webinar regarding breast cancer awareness. This webinar is being put forward by the Imamiya Medics International Women's Wing, Michigan chapter with regards to the Breast Cancer Awareness Month. First of all, we'll begin with the recitation of holy verses. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم إنا آتيناك الكوثر فصل لربك وانحر إنا شانئك هو الأبتر. Translation. In the name of Allah, the most beneficent, the most merciful. O Prophet, we have surely bestowed upon you good in abundance. So offer prayer and sacrifice to your Lord alone. Verily, your enemy alone has been cut off from the roots. Sadaqallahul Azim. I once again welcome everybody, all the audience from different parts of the world who are joining us today live on Imamiya Medics International YouTube page, also called as My TV, for the Women's Wing Breast Cancer Awareness webinar being brought to you by the Michigan chapter. To introduce Women's Wing to all of our viewers who are new to us, I would like to play a short video, so that we can have some idea about what Women Wing does.
Imamiya Medics International is one of the world's leading healthcare, humanitarian, education, and relief organizations that has been serving humanity for the past 27 years. What started as a noble effort of few friends in a New York basement has today mushroomed into a global initiative that has welfare projects running in 55 countries. Working for the poor, neglected, and disadvantaged people through various programs and helping improve their lives. Throughout history, the central role of women in society ensures stability, progress, and long-term development of nations. Since its inception, women volunteers at IMI have played a foundational role and acted as a pillar of relentless support in its long, painstaking, yet rewarding journey. IMI's Women Auxiliary is a platform for the motivated and inspired women that are ready to change their world for the better. IMI Women Auxiliary is a step towards empowering women through provision of education, health services, and various training programs. To fulfill these, IMI's Women Auxiliary organizes seminars, skill development workshops, e-training and support sessions, career guidance, and financial support initiatives. Through its various working groups, the Women Wing intends to educate, change, and implement policies which help accelerate women's sustainability around the world. From transferring latest medical technology and research to students in war-torn Iraq, to providing primary, basic hygiene education to girls in impoverished Nigeria. Helping design innovative techniques to fight coronavirus in India, helping girls prevent childbirth mortality in Thar Desert of Pakistan. Free basic healthcare screening for the elderly and people without insurance in the US. Supporting future leaders with Flagship Nest program in New Jersey, an all expenses paid initiative where foreign medical students receive free stay, food, and career guidance. Zahra Social Networking, an initiative to address social issues such as mental health amid COVID-19. Women's Wellness Program that aims at educating women in adopting a healthy lifestyle. All these wonderful initiatives are possible thanks to the combined experience and knowledge of the diverse set of medical experts, academicians, and social workers that are an integral part of IMI's Women Wing. Yet, there's still a long way to go. Much more remains to be achieved, and through each step, we will need your prayers, financial support, and active participation. Our vision lies in growing IMI Women Family one meaningful wing at a time, adding new members in our journey to empower women worldwide.
So that was a very brief video about just the activities from Women's Wing. And now I would like to welcome and introduce Dr. Saba Azhar for a welcome note. Dr. Saba Azhar, she leads the Michigan chapter of the Women's Wing. And not just that, she has graduated from Dow Medical University, Karachi, Pakistan, and did her residency in internal medicine from Stanford Hospital, Connecticut, Columbia University program. Then she did her fellowship in geriatrics and from Central State Robert Wood Johnson School of Medicine. And currently, she is a senior staff physician in geriatrics at Henry Ford Health. I would like to welcome you, Dr. Saba Azhar. Thank you for joining us.
Thank you so much, Verda. My honor. And I thank everyone for joining us this morning because, this is such an important webinar about breast cancer awareness for women. As you all know that one of IMI's mission is to promote community-based health programs and to increase our community's awareness about health and well-being. So this webinar is just an extension of that for a very important topic pertinent to women's health. And I'm very grateful that IMI headquarter and the Women Wing President, Chairman, Dr. Homa Naqvi gave us this opportunity to conduct this webinar. And I'm very grateful to our esteemed physicians who are present today, who are very knowledgeable. And I'm pretty sure that anyone who will listen and attend this webinar will benefit from the information. There's just a disclaimer that, we are not giving practical medical advice. So this is for your knowledge. We're imparting the knowledge and trying to educate you about this important cancer, breast cancer. But if any one of you is suffering from any sign or symptoms, or you feel you're not, after listening to this webinar, you have some concern about your health in terms of, breast cancer, please consult with your primary care provider who is going to guide you and send you to refer you to the specialist that you need to see. So with this, I would like to introduce our first presenter, Dr. Kulsum Jaffrey, who is, again, I would say all these women present here are super moms because, handling the personal and professional life side by side is very time consuming. And Dr. Kulsum Jaffrey is a native from New Jersey. And she has lived, she's now married and living in Detroit, and she is working in a private practice in her specialty OBGYN. Um, and she is a very important community member. Besides being a great physician, she's always there to render help to whoever needs it. So I'm very honored to have her today. And of course, Dr. Hadil Asad, which we will be introducing later on. So I don't want to take too much time, and I would like to ask Dr. Kulsum Jaffrey to please begin your presentation. Thank you.
Sure.
Assalamu alaikum, everybody. Thank you for joining. Thank you to Imamiya Medics International for all that they do, and especially to Dr. Sabah for starting the Women's Wing in Michigan. It's crucial to our communities, and inshallah will make a huge difference for many of the women here locally as well. So breast cancer a lot of times is a taboo subject, especially amongst our Desi communities, and I would say just culturally speaking, a lot of us don't talk about it. We don't mention breast health, and this is part of why we're doing this webinar, is because it's very important. And often we as women neglect our own health, and this breast cancer topic can affect anybody, even if you have no risk factors. So we'll just start out very basic. What is breast cancer? It's a type of cancer that starts in the breast tissue. It involves a change in the DNA, which is your genetic material at the cellular level. And cancer in general is when abnormal cells in the body multiply and they can spread to other parts of the body as well. Breast cancer has now become the second most common cancer in women in America, with skin cancer actually being number one. We don't know the exact cause of breast cancer, but we do know that there are several risk factors that we will go over as well. Next slide, please. Just to briefly go over the anatomy of the breast. Each breast has 15 to 20 smaller sections inside called the lobes, and these are connected to the nipple via ducts, okay? Beneath this or around this lobular area is fatty tissue, and then deeper to the fatty tissue is muscle. It's important to review the anatomy briefly, just because when you are doing a breast exam, which we'll go over shortly, you kind of know what want to know what you're feeling for. And then lastly, there's lymph nodes as well that drain the breast tissue. So just like if you're ill with some other like upper respiratory infection or something else, oftentimes your lymph nodes will become enlarged in your neck or elsewhere. Specifically for the breast, if there's a tumor or a cancer growing in the breast, sometimes the lymph nodes in the axilla or the underarm will become enlarged. So if a lump is felt in the underarm, that should be a cause for concern as well. Next slide. So just to briefly go over the epidemiology or how common breast cancer is. Like I said before, breast cancer can affect anyone, and it is present in every single country around the world. In the US itself, 1 in 8 women in the United States will be diagnosed with breast cancer, which is approximately a 13% chance of a woman being diagnosed in her lifetime, which is a pretty high number if you think about it. Over half of women diagnosed with breast cancer have no specific risk factors except for age. Usually it will affect women who are over 50, but again, can happen at any age, even younger women in their 20s or 30s. Just this past year, or in 2024, they were estimating that over 300,000 women will be diagnosed with breast cancer as a new diagnosis. So there's modifiable risk factors and non-modifiable. Modifiable are going to be the ones that you can modify or change. Weight management, so obesity is a risk factor. Smoking, alcohol, which we don't need to worry about that. Hormone replacement therapy, and this is a whole topic in and of itself, but mostly for menopausal or postmenopausal women, sometimes doctors will offer to put you on estrogen or progesterone to help with hot flashes and other symptoms, insomnia, mood swings that can come with menopause. And there have been studies that have shown that being on a high dose for a long time can put you at risk. Birth control pills, again, we're talking daily use for over 10 years of a higher dose. So just being on birth control pills for a short time is not going to put you at risk, but prolonged use certainly can put you at risk for cancer down the road. And lastly, interestingly, breastfeeding can actually decrease the risk of breast cancer. And then non-modifiable risk factors are going to be things that you can't change. Your age, especially women over 50, as I mentioned before, are at higher risk. Extra hormonal exposure. So the studies have shown that the more exposure to estrogen that you've had in your lifetime, be it through the hormones that I mentioned before or through natural hormonal production, you are at a slightly higher risk. So girls who have their period at less than 12 years old, women who are going through menopause after age 55, women who have their first child after age 30, or women who have never been pregnant. Now, a lot of us are going to fall into these categories. Again, this doesn't mean that you're going to get breast cancer. We're just briefly reviewing things that would put you at a slightly higher risk. Um, Radiation exposure to the chest as a child or a young adult. Um, there's hereditary risk as well. So again, this is something you cannot change. We'll talk a little bit more about the BRCA or BRCA gene mutation. Um, and then family history. So if there's a family member who's been diagnosed at age less than 50 in your family with breast cancer, or more than one family member has been diagnosed with breast cancer at any age, especially a first-degree relative. So that would be a mother, sister, or a daughter. These are some of the non-modifiable risk factors. As far as screening for breast cancer, so screening, just to briefly go over definitions, is when we're looking for signs of a disease before the symptoms develop. And this is a crucial part to detecting breast cancer early. And the goal is to catch it early so that it can be treated and cured. There are a couple of different ways to kind of screen for breast cancer. There's the self breast exam, which I'll touch upon briefly, clinical breast exam, which is when a physician is doing your exam, or the mammogram, which is a special X-ray test to screen for breast cancer. Currently, the self breast exam and clinical breast exam can be controversial depending on which association guidelines you're following, but with the American College of OBGYN, we are still recommending that women do a self breast exam monthly and a clinical breast exam yearly, preferably, but every 2 to 3 years. And then the mammogram is going to be the number one way to screen for breast cancer. And we'll go over that as well. So how to do a self breast exam. So the first thing you want to do is inspect the breast. And again, the best time to do this is usually after your menses has completed. So after you're done with your period. If you are done having periods and you're menopausal, then just one day a month. Pick any day of the month and just make it as part of your routine. But you basically stand in front of a mirror with your hands on your hips and you're examining the breast, looking for changes such as puckering of the skin, a change in the size if one breast is looking larger than the other, a change in the nipple or breast shape, as well as nipple discharge. And then we'll talk about lumps in a minute. So when we do a self breast exam, basically what you're going to do is, again, once a month in the shower, usually following your period is the best time to do it. So after you've inspected your breast in front of a mirror, the next thing is going to be palpation or checking with your fingers. So basically, once a month in the shower, you're just going to lift your arm above your head. So just like this. And then you're going to use 3 fingers and basically start up by your collarbone and you're going to feel all the way around the breast. So there's different ways to do it as seen in this example. You can do a like up and down. So from the collarbone, go up and down. Or you can do it in a circular fashion, almost like a spiral. And the key is to just check the entire breast. So don't get caught up in the method. It's you really just want to start at the collarbone, go all the way around, and then also check under the arm as well for those lymph nodes. And, a lot of times you don't know what to feel for. It's overwhelming. So I would say that, do the initial exam. If you do feel something and you're concerned, you can certainly call your physician. But checking again the following month, and if it's still there, then you definitely would want to follow up. A lot of times you are going to feel just fatty tissue or some little lobules that are benign or not cancerous. But the ones that we're going to be more concerned about are if they are hard, tender, not moving when you push on it, almost like a hard marble, then it is best to get checked out. And then again, if you feel a lymph node in the underarm, you're going to want to get that evaluated as well. So what happens if you feel a lump? I always say don't panic, but don't ignore it either. So if you do feel something on the exam, it's best to get checked out. And if it ends up being nothing, then that's great. But we don't want to ignore something that we feel. So if you do feel a lump, typically what will happen is your doctor will do an exam in the office, and then a special kind of mammogram. So aside from just the basic screening mammogram, will be ordered. It's called a diagnostic mammogram. And that will specifically look at that breast where you felt something or your physician felt something. And then typically we'll order a breast ultrasound as well, because this will help us decide if it's just like a cyst, or is it fatty tissue, or something called a fibroadenoma. Um, just keep in mind that none of these actually diagnose breast cancer. So they're used as tools to help us, but truly the only way to diagnose a cancer is through a biopsy. And so if a lump is seen, or a mass is seen on the imaging, then the next step is typically a biopsy, to make sure that it's not cancerous. And that's usually done by radiology or a breast specialist. Oops, I'm sorry. Can you go back one more slide? Oh, we did go over all of that. Sorry. Okay, next slide. Okay, so what is a mammogram? So a lot of you have heard of a mammogram. Some people are terrified to get it done because of this concern that it's going to hurt or it's squeezing and pressure. It's one of those things that you get done once a year and then it's done. So it just takes a few minutes. It does involve the breast tissue being placed like so, and it is pressed between two plates while an x-ray is, or a picture of the breast is taken. General screening guidelines, like I mentioned before, mammogram is going to be the most common and number one screening tool for breast cancer. And it should be done every year starting at age 40 until about age 75 or 80. There isn't an official cutoff per se, but the studies have shown that women will die from more common things at age 75 or 80 than breast cancer, such as heart disease and other things like that. So the screening is not necessary, past those age ranges. Now, this every year is also debatable. Again, the American College of OBGYN recommends every year, but American Cancer Society and some other organizations may say every 1 to 2 years. I still push to do it yearly, because breast cancer is one of those things that could come out of nowhere and we want to catch it early. Exception to this rule is if you do have a family member, particularly a first degree relative, so like I mentioned, a sister, a daughter, or mother, who was diagnosed, let's say at age 40, then your screening should begin 10 years prior to the age of diagnosis of that family member. So briefly to touch upon BRCA testing, or BRCA testing. So up to 15% of women who are diagnosed with breast cancer will be, the cause will be this inherited gene mutation. So we all have the BRCA gene, but whether it gets mutated or those cells change is what we're discussing here. So genes are like instructions for cells. They tell cells what to do. So if there's a harmful change or a mutation in the gene, this can increase your risk of cancer. So we're able to test for two of these genes, the BRCA1 and BRCA2 gene mutations, which can be hereditary. And if positive for BRCA1 or BRCA2, there is a 45 to 85% lifetime risk of breast cancer, which is significantly high, and a 10 to 45% risk of ovarian cancer. So they have found a correlation with breast and ovarian for patients who carry this gene mutation. So who should get tested? There is specific criteria for testing, but just to go over the general guidelines, if you yourself have a personal history of breast cancer at age less than 50, the recommendations are for you yourself to get tested, to see if you could potentially pass this gene on to future generations. If a close relative, mother, sister, grandmother, or aunt have been diagnosed at age less than 50, if there are multiple cancers on the same side of the family, a blood relative who has been diagnosed with pancreatic or prostate cancer. Um, more rare cancers, such as a personal or family history of male breast cancer or ovarian cancer. And then young cancers, so breast, colon, or uterine cancer diagnosed at age less than 50. These are people who the recommendations are to get tested. So how do you get tested? It's done through either blood work or saliva, depending on where you get the testing done. Most of our offices as OBGYNs, we will carry the kits in our office and can do the blood work or saliva test on site. And it typically takes 10 to 14 days for those results to come back. Oftentimes, if patients do have a strong family history, we will refer them to a genetic counselor to go over the risks for the patient themselves. And the genetic counselor can generally order this test as well. And some family doctors are now carrying testing kits for hereditary cancers as well. So you can certainly ask there as well. So what does a positive test mean if you do end up being positive for the BRCA gene mutation? Usually we'll refer patients to genetic counseling just to discuss in more detail about family history and the chances of being diagnosed you yourself or to future generations. The patient themselves will be undergoing more enhanced screening. So in addition to that yearly screening mammogram we talked about, we'll also do a breast MRI to get a more detailed look at the breast tissue. We would also recommend a yearly vaginal ultrasound and a CA-125, which is a hormone level that we can check in the blood. This is because of that increased risk of ovarian cancer that has been linked to the BRCA gene mutation too. And neither one of these diagnoses ovarian cancer. Again, it's just kind of a screening tool to catch something early. And then possibly start screening earlier than age 40 for these tests. Some women will decide to proceed with what we call risk-reducing surgery. So as I mentioned, the lifetime risk, if you do test positive for one of these gene mutations, is 45 to 85% for breast cancer. That's very high. So some women don't want to even take that chance. They don't want to go through all these tests every year. They'll just decide to remove whatever the tissue is that is of concern. So some women will undergo bilateral mastectomy to remove both breasts just to completely eliminate that chance of ever getting breast cancer. And some women will even proceed with removing their ovaries because of that risk of ovarian cancer that we talked about as well. There are also risk-reducing medications. We call them chemoprevention to help reduce the chance of progressing to a cancer. So that kind of concludes my portion. I just listed some helpful websites. There are plenty of self-breast exam tutorials available online that are just very short clips if you're still confused on how to do it. Like I said, pick one day a month or after your cycle is done, or even just the first of every month to do this very quick exam that takes less than a minute in the shower.
All right. So is there anything more you'd like to add, Dr. Kulsum?
That's it for now, and I'll be available for questions at the end.
All right. Thank you so much, Dr. Kulsum Rizvi Jafri. I would like to mention that Dr. Kulsum had a very busy weekend when we were, preparing for the webinar, but she was kind enough to join us throughout that as well. And I would like to mention that she's a medical graduate from Medical College of Virginia, and she did her residency there as well. And currently she is in a private practice as an OBGYN in Sterling Heights, Michigan, and is also affiliated with Troy Beaumont Hospital. Thank you so much again, Dr. Kulsum Rizvi Jafri. We'll definitely get back to you at the end for the question answers, and the presentation was very informative. Now, I would like to introduce our next speaker for today, Dr. Hadil Asad. Dr. Hadil Asad is a medical graduate from the University of Jordan, Amman, Jordan. She did her residency at MSU Southeast Michigan campus and Providence Hospital and Medical Center. Then she completed her fellowship of hematology and oncology again at MSU Southeast Michigan campus, Providence Hospital and Medical Center in Michigan. Dr. Hadil Asad is the co-leader of the breast cancer multidisciplinary team at the Barbara and Karmanos Cancer Institute. She is an associate director of Hematology Oncology Fellowship Program and also an associate professor at Wayne State University School of Medicine. We welcome you, Dr. Hadil, and we are honored to have you.
Thank
Thank
you,
you.
Warda, for the introduction. Salam alaikum, everyone. I'm very happy to be here, and I want to thank the IMI organizers for inviting me to talk about a topic that I'm very passionate about, and that's breast cancer awareness. I'll be touching on management, including diagnosis, treatment, and prevention. As you heard from Dr. Jaffrey, breast cancer is the most common cancer in women if you exclude skin cancer, with about more than 300,000 new cases of breast cancer that are estimated to be diagnosed in 2024. In the US, it's the second most common cause of cancer-related death after lung cancer, with an estimated 42,000 women that will die of breast cancer this year. Around the world, it's actually the number one cause of cancer-related death in women. And that's partly due to the lack of screening and the late-stage diagnosis in many other countries. If you look at the incidence, which is the cases of new diagnosis of invasive breast cancer, you can see that the trend increased, the incidence increased in the 1980s, and that's with the rapid uptake of screening mammography here in the US. It then plateaued and decreased in the early 2000s, and that's when we discovered that hormone replacement therapy is directly related to or increases the risk of breast cancer, and there was a decrease in use of hormone replacement therapy at that time. The other good news is that if you look at the age-adjusted cancer death rates, you can see that for all cancers, but especially breast cancer here in the pink, that the death rate from breast cancer is decreasing from the early 1990s. And that's due to screening, early detection, and better treatments that we have available. As you heard, breast cancer can be diagnosed when a patient or person presents without any symptoms, and an abnormality is detected on a screening mammogram. That's when we usually like to diagnose cancer, when it's asymptomatic, because it's usually earlier stage and it's easier to treat and has better outcomes. Sometimes a patient might present with symptoms, and we'll go over some of these symptoms again. Imaging will be necessary when a person has symptoms of breast cancer. As you heard from Dr. Jaffrey, a diagnostic mammogram will be ordered. And that's different than a screening mammogram, because a diagnostic mammogram, the radiologist has an area to look at. There's actually a marker that's placed on the breast where the abnormality is, and they focus on that abnormality. Additional imaging, such as ultrasound and MRI, might also be ordered. Ultimately, a biopsy is needed to diagnose cancer, as you heard, and pathologic confirmation of the type of breast cancer, the grade, the hormone receptors is all needed. So what are the common signs and symptoms of breast cancer? Most common is a painless lump. However, some patients do present with a painful lump in the breast. Any discharge from the nipple, especially if it's bloody discharge, should raise suspicion of breast cancer. Change in the size or contour of the breast. Nipple inversion, especially if this is new. Change in the color or appearance of the areola, which is the area around the nipple, such as sometimes eczema of the areola can be a sign of underlying breast cancer. And redness or pitting of the skin over the breast, which looks like an orange peel appearance. Ultimately, it's just important for you to know what feels normal for you and report any abnormalities to your medical provider so that appropriate workup can occur without a delay. On mammogram, cancer looks like a white mass in a background of grayish breast tissue. And based on the characteristics of this white mass, the radiologist can tell us if this is suspicious for cancer or not. Ultimately, as you heard, a biopsy will be needed. A biopsy can occur, there are three types of biopsies, either a fine needle aspiration, where there's a collection of sample of cells, or a core needle biopsy under ultrasound guidance, or even surgical biopsy, which is an open biopsy. And a small amount of the breast tissue that's abnormal is removed so that it can be examined under a microscope by a pathologist. And the pathologist will tell us if this is normal or precancerous, such as DCIS, or invasive breast cancer. Now, is it true or false? All breast cancer is treated the same way with surgery, radiation, and chemotherapy. This is actually false. Breast cancer is not one disease. There are 3 or 4 different types of breast cancer with molecular differences and receptor differences that result in treatment differences and differences in outcomes as well. So not all breast cancer is actually treated the same. When thinking about breast cancer management, you can divide it up into 2 broad categories. Early stage, which is stages 1, 2, and 3, where the cancer is localized to the breast and regional nodes. The treatment typically is multimodality and involves surgery, radiation, and systemic therapy. The goal of treatment is with curative intent. When the cancer is beyond the breast and regional nodes to other and involves other organs outside these areas, that is stage 4, breast cancer, in which the mainstay of treatment is systemic and the goal of treatment is different. Here it's palliative, meaning that the goal of treatment is to prolong life and preserve quality of life. However, in 2024, we still are unable to cure stage 4 breast cancer. When you look at breast cancer outcomes, you can see that the 5-year survival rates differs according to the stage of diagnosis. You can see that stage 0 and stage 1 is associated with a high rate of breast cancer survival, with greater than 98% of women actually living beyond 5 years. It does go down as you progress in the stages. And that's why we like to diagnose breast cancer when it's earlier stage, because it's associated with better outcomes. And the treatment is also easier. So we'll start with early stage breast cancer treatment. Surgery is a part of the management for early stage breast cancer. And in general, a woman can have a mastectomy, which is removal of the whole breast, or a lumpectomy, which is removal of the lump with a margin of normal breast tissue around it. When we add radiation therapy to the whole breast after a lumpectomy, we call that breast preserving surgery or breast preserving therapy, and that is equal in terms of survival and recurrence to a mastectomy. So we actually favor preserving the breast whenever possible. The decision between a mastectomy and a lumpectomy really comes from whether or not you're able to remove all of the area that's involved and leave enough breast tissue behind where it looks cosmetically acceptable. There are other indications where a woman must have a mastectomy instead of a lumpectomy, such as if it's multifocal or multicentric, involving multiple different quadrants of the breast. If it's involving the skin, if there's inflammatory changes, then a mastectomy is necessary. However, most of the time, we can get away with a lumpectomy and whole breast radiation, which has a lot less complications and a lot less morbidity. Lymph node evaluation is important, regardless of the type of surgery that you have, because it gives us some prognostic information and it also helps with treatment. It's important to predict after surgery the micrometastasis risk, which is what is the risk that there are cancer cells floating around that we can't see that can give us a problem in the future. And we estimate that risk by using the tumor biology, such as size, the number of nodes or lymph nodes involved, the grade, the receptors, and other genomic assays can also be used. When you do a lumpectomy, like I mentioned, it's important to check the margin, which is the tissue around the mass or the cancer, and make sure that it's not involved. Here you can see that the cancer is involving the edge of the specimen, and this is a positive margin, which requires re-excision. Again, very important to sample the lymph nodes, which is done at the time of surgery, because it guides the radiation oncologist as far as how far the radiation field needs to go, and also gives us important prognostic information. Radiation therapy is essentially high-dose X-ray that is delivered to the area. There's two types of radiation therapy, and it eradicates the cancer cells in that area. Whole breast radiation is always performed after breast-preserving surgery or a lumpectomy. The radiation therapy is typically Monday through Friday for 4 to 6 weeks. However, it only lasts less than 10 minutes each time. And the side effects are local. The radiation oncologist will discuss this all with the patient. Post-mastectomy radiation, which is after removal of the whole breast, can also occur in certain situations, or there are certain indications. That's if the cancer is larger than 5 centimeters, if the margins remain positive, or if there are positive lymph nodes at the time of lymph node evaluation, then chest wall and regional node radiation would be necessary. Systemic therapy is anything that you take that's IV or oral that will go everywhere to your entire body and prevent the cancer from returning or spreading. Because that's really what we worry about, is the cancer returning elsewhere in the body. Chemotherapy is a part of systemic therapy. However, typically it's only reserved for triple negative breast cancer, HER2 positive, and high-risk hormone positive breast cancer. In fact, 70% of hormone positive breast cancer does not require chemotherapy and will not benefit from chemotherapy. And so we can safely avoid chemotherapy in a large portion of women with breast cancer. Hormone receptor positive breast cancer is the most common type of cancer in women, in which they're both the estrogen and or the progesterone receptor are expressed and the HER2 receptor is negative. In general, when we give chemotherapy, it reduces the risk of distant recurrence or metastasis by 1/3. Hormone therapy is actually the most important part of breast cancer treatment, and these are with pills that you take for 5 to 10 years. I listed some of these pills. They include tamoxifen or an aromatase inhibitor, such as one of the 3 that are listed. Some people think because this is oral that it's less important than chemotherapy, and that is not true. It's actually more important because it reduces the risk of cancer recurrence by 50%. It reduces the risk of new breast cancers in either breast by 50 to 75%. And as you heard from Dr. Jaffrey, can be used for prevention for women who don't have breast cancer but are at high risk of breast cancer during their lifetime. Other systemic therapies include HER2-directed therapy. When the cancer presents us with a target, we like to target it. So HER2-directed therapy includes antibody treatments against the HER2 receptor, such as trastuzumab and pertuzumab. This is very specific for HER2-positive breast cancer, and it actually has changed the prognosis of this subtype. HER2-positive breast cancer used to be a poor prognostic factor. Now with these therapies, it actually is a more favorable prognosis. There are other forms of targeted therapies that are not chemotherapy, such as immunotherapy. There are pills that are listed here, like olaparib, which is used in germline BRCA 1 or 2 mutation carriers who have breast cancer and high risk of recurrence, and other medications that sometimes we overlap with hormone therapy, such as the CDK4/6 inhibitors. Bone strengtheners are also important because they not only do they help strengthen the bones, which can be a side effect of some of these hormone therapies, it actually also prevents recurrence and improves cancer-free survival from breast cancer. So we utilize these medications quite a bit. Now, jumping to metastatic breast cancer. Metastatic breast cancer is when their cancer cells spread from the primary tumor, which is the breast, to distant sites of the body. And that can be either through direct invasion, seeding via the lymphatics, or via the blood vessels. And that's the most common way that cancer metastasizes, is through the blood vessels. Breast cancer can really go anywhere. It can involve the lungs, the brain, the liver, and most commonly, the bones. As we mentioned before, when the cancer spreads to another organ, it is a stage 4 cancer, which is not a curable cancer. However, it is a treatable cancer, and the goal of treatment is, again, to prolong life and preserve quality of life. The mainstay of treatment is systemic therapy, which is a therapy I mentioned that's IV or oral, and it goes everywhere, targets all of these lesions. Radiation and surgery are used on an as-needed basis because if you can't surgically remove all of the cancer, removing some of the cancer and leaving the rest behind does not make you live any longer. But we use surgery and radiation for problem areas to relieve compression on a vital organ, to help with alleviating pain and other complications of the cancer. There are very specific algorithms and guidelines we follow when we're treating stage 4 breast cancer. And it's very important to consider a clinical trial. Actually, when you have breast cancer at any stage, it's important to consider any clinical trials that you would be eligible for, because ultimately that's how we advanced medicine. That's how we got to where we are today. And also, you get the opportunity to receive medications that are the newest drugs in development that are otherwise not available outside of a clinical trial. This is just to show you the treatment algorithm for metastatic breast cancer. We go from one line to the next based on response and tolerance. The treatment is typically indefinite, meaning that the person will have to remain on some sort of treatment to control the disease, such as just like diabetes or hypertension is not cured and you have to take medication to control it. Same thing with stage 4 breast cancer. The medications highlighted in green are targeted therapies, which are, again, they target either a receptor or a biomarker or a mutation in the cancer. So it's a very specific type of treatment. And actually, every couple of months, this treatment algorithm changes because there's a lot of research going on in this field to try to improve patient outcomes and prolong survival. And this is what we call precision medicine. When you target the molecular markers or the mutations in the actual cancer, rather than giving the traditional, cytotoxic or general cytotoxic treatments such as chemotherapy, radiation, and surgery. We are in the cancer treatment world utilizing precision medicine more and more often because it actually is associated with better outcomes. The best way to treat cancer is, of course, to prevent it from happening altogether. So how can you prevent breast cancer? By obtaining and maintaining a healthy weight. Excuse me. It is recommended that you stay at a BMI of 18.5 to 25, using a low-fat, low-carb diet, staying physically active. The American Cancer Society recommends 115 minutes of physical activity per week, which is around 30 minutes of walking per week. Avoid alcohol intake, and alhamdulillah, Islam prohibits alcohol, so we don't have to worry about that. Know your family history. Dr. Jaffrey talked about preventative surgeries that may be offered to high-risk individuals. And then primary prevention, like we mentioned, with tamoxifen or raloxifene can be used for women who have a high risk of breast cancer, even if they don't have cancer themselves. Don't delay your screening mammogram. If you're due, we do recommend that you get your mammogram, as you heard, once a year starting at age 40. You can schedule your mammogram by calling your primary care. I've listed some, I work at Kermano, so you can schedule your mammogram online or by calling the 1-800-KERMANOS number. For uninsured or underinsured women, you may qualify for free breast and cervical cancer screening through the BCCP program, and you just have to apply online. There's actually a lot of foundations that can cover breast cancer screening in multiple different countries and states, and so sometimes social worker can help you identify those. So in summary, all cancers start at the level of the gene. However, only 5 to 10% are actually hereditary, can be passed down from generation to generation. As you heard, certain mutations may increase the lifetime risk of breast cancer. In general, 1 in 8 women will develop breast cancer, but mutations such as the BRCA mutation may increase the lifetime risk to 80%. Important to know your family history. It's important to screen for breast cancer because early detection is key. Consider additional testing if you have dense breasts. Nothing really replaces the mammogram. You still have to get your mammogram, but there are additional other tests that can be used to help identify abnormalities. And then work up any breast symptoms that you have. Even if you had a recent negative screening mammogram and you present with symptoms, you should reach out to your medical provider and get appropriate workup, because we do see sometimes cancers develop between the screening mammogram. These are some resources that you can also seek additional information on breast cancer. And I'm happy to take any questions.
All right, that was very informative and very in-depth. Thank you so much, Dr. Asad. Thank you for all this information and guiding us. Now, I think we would like to move on to our question answer session with both the speakers. And we have some questions coming up from the audience, and I'd like to mention those to a certain speaker, and if the other speaker would like to add anything, that's perfectly all right. So the first question is for Dr. Kulsoom. So Dr. Kulsoom, someone's asking that could there be any link between changes in the monthly female cycle with the breast cancer? Dr. Kulsoom, you're mute. I request you to unmute, please.
Hi, I'm back. So as I mentioned before, the more estrogen or hormonal exposure in your lifetime, the higher the risk of breast cancer. So getting a period, starting your periods earlier, less than age 12, or going through menopause later after age 55, you're going to have more cycles in your lifetime. And so this puts you at a slightly higher risk. As far as changes like in a monthly, so let's say some girls or women are skipping cycles or things like that. In general, that itself doesn't necessarily pose you at an increased risk for breast cancer. Certainly, as you get close to menopause, you will start skipping cycles. That's part of the perimenopause stage. So that in and of itself doesn't change your risk necessarily. But like I mentioned before, the earlier you start or the later you end, the higher the risk.
Right, right. Thank you. So now coming to Dr. Asad, if someone gets diagnosed with a cyst in the breast, does it increase their chances of breast cancer?
So there is a slight association with benign breast biopsies and cancer, okay? It's not necessarily that this cyst is going to transform into cancer. There are precancerous lesions such as atypical ductal hyperplasia or in situ disease. We call them lobular carcinoma in situ, ductal carcinoma in situ. These are precancers that may transform into breast cancer in the future. So we do treat them sometimes very similar to breast cancer. So I would say there is a slight increased risk of benign breast biopsies. So you get, a biopsy for a cyst, and it's found to be benign with breast cancer in the future. There are actually certain calculators that you can use online to estimate your risk, your individualized risk of breast cancer. I like to use the GAIL model. It's free, it's online. The GAIL is GAIL. You can punch in your information, and they do actually include whether or not you've had a previous benign biopsy. And it estimates what is your risk of having breast cancer in the next 5 years. If your risk is higher than 1.67%, then you might actually qualify for primary prevention or chemoprevention with the medications we talked about. So I think it's important for women in general to know their own personalized risk, because not everyone falls in the general population risk of 12 or 13%.
Right. All right. Thank you so much. Now, Dr. Kulsoom, there's a question that does breastfeeding have any impact in decreasing or increasing in any way the chances of breast cancer?
Yeah, so I just briefly touched upon it in the presentation. So there have been studies that have shown that breastfeeding does decrease the risk of breast cancer. And perhaps the theory behind this is that a lot of times when women are breastfeeding, they won't have a period or they won't get a cycle because of hormonal influences. And so that link between the less periods, the less the chance of breast cancer down the road, as a general statement, can be tied to breastfeeding as well. So, so yes, the studies have shown that the breastfeeding, along with all the other benefits that are mentioned in Islam, can decrease the risk of breast cancer as well.
Perfect. Perfect. Thank you so much. And another question for Dr. Asad. For women previously exposed to radiation for the treatment of any other types of cancer, does it increase their chances of breast cancer in particular?
Yes, that's a very important question. So women who have Hodgkin's lymphoma, as usually when they're young, they're usually teenagers, as part of their treatment will get radiation therapy to we call it mantle radiation, which is this area right here. And that actually covers a good portion of the breast. These women are at increased risk of breast cancer up to 40 times higher than the general population. So they should undergo high-risk screening, such as a mammogram alternating with breast MRI every 6 months. So that's important to know. It's of course not common for women to have or radiation to this area. It's only done if they're diagnosed with certain types of cancers as child or a teenager, but they are increased risk. Now, radiation exposure from your regular X-rays or CT scans, or it's very, very minimal. And that does not increase your risk of breast cancer. We're talking about radiation therapy. So not your regular, scans or imaging.
Right. Right. Perfect. So the last question is for both the speakers. So we'd request both of your inputs. Does menopause affect in any way it can affect the breast cancer from the hormonal aspect? Or it can increase the chances or decrease the chances, or in any way the hormonal changes when menopause occurs, does it impact the probability of having a breast cancer or anything? So Dr. Kulsum, I'd request your input first.
So as I mentioned before, age by itself, so after age 50 by itself is a risk factor, and is one of the main risk factors. So if you tie that into when women go through menopause, the average age is 52. So just age by itself would put you at an increased risk. From a hormonal standpoint, again, like the more estrogen exposure, the more hormonal exposure during the lifetime is going to put you at a higher risk. So if you go through menopause earlier, age 47, 48, then your risk is slightly less. And then separately, as I mentioned, hormone replacement therapy, and Dr. Asad also mentioned that you saw a decline in the risk or the incidence of breast cancer once the studies came out that there's a direct link with HRT and breast cancer. Doctors are prescribing it less. So along those lines, if you are menopausal and you're put on hormone replacement therapy, depending on the dosage, how long you're on it, that can also put you at a slightly higher risk.
Right. Thank you so much. Dr. Asad, would you like to add anything?
Yes. So as Dr. Jaffrey mentioned, breast cancer is a cancer of the elderly. The average age is actually 65. However, we do see breast cancer in women in their late 20s up to, above 90 years old. Now, it's important to identify the menopausal status of the patient that presents with breast cancer because the treatments are different. Women with breast cancer tend to have less aggressive cancer and better outcomes. More often, they are hormone receptor positive breast cancers. Premenopausal women who are younger, when diagnosed with breast cancer, typically have more aggressive types of breast cancer, such as the triple negative breast cancer. So I think that maybe differs. There's actually different ways we calculate the risk of cancer metastasis, whether a patient is postmenopausal or premenopausal at diagnosis.
Right, right. Thank you so much. I think those were all the questions that we had, but they must be very much eye-opening for the audience. Now, I would request Dr. Sabah Azhar to please say a few words as a thank you note. Dr. Sabah Azhar, over to you.
Yes, thank you so much, Verda. I want to first of all thank you also for helping us coordinate this webinar. We appreciate your time and efforts. And for the organization, I also want to thank Ashar Bhai for the media support. And definitely, I want to take this opportunity, first of all, to thank Dr. Waji Rizvi, who's the founder of IMI, and Dr. Huma Naqvi, who's the global chair of IMI Women Wing since 2019. And she has been involved in so many global projects associated with IMI. And I thank IMI for giving us this platform to, help the women and all men and women in our community gain some awareness about their health and well-being, which is so crucial. And, I particularly like webinars because any person can log on, listen to the information that we are sharing. And of course, last but not the least, I want to thank Dr. Hadil Asad and Dr. Kulsum Rizvi Jafri for the valuable information that they shared in this webinar. It was so amazingly knowledgeable and so easy for anyone to follow the information that they shared. And I hope that that our community, especially the women of our communities, benefit from this webinar and pay attention to themselves and to their health. So I thank you all for being here, and especially on a Sunday, which is our family time, taking out time for the community on Sunday. Special thank you to you all.
Thank you so much on behalf of the whole team of Imamia Medics International Women's Wing, and on behalf of Dr. Huma Naqvi, the Global President of the Women's Wing. I would also like to thank the Michigan chapter, and I would particularly like to mention that Dr. Saba Azhar has been very, very active, very cooperative in bringing this whole project together. I would also like to thank our esteemed speaker, Dr. Kulsum Rizvi Jafri and Dr. Hadil Asad, the media team, Sarah Shahzadi. And inshallah, we will see everyone again in another informative webinar soon again on my TV, YouTube.
Thank you so
Everyone,
much.
thank you for joining us, all the audience. Take care of yourself. Allah Hafiz.